Well, thank you very much, Bishop. It's a pleasure to be here today, and I'm happy to be able to talk. I always like to begin. This is a quote from Francis Collins, who's the director of the American National Institutes of Health, where he says, when I was a medical school professor in Ann Arbor, which is the University of Michigan, a few years ago, I think I said it was easier to sequence the human genome than to change an hour of medical school training, and it's still a challenge to do that. And in many places, that really is still the case. For better or for worse, curricular integration is really being driven by a number of agencies now. In the US, the American Medical Association, the AAMC, the Association for American Medical College of Medicine, the LCME and MBME, the people that do the exams, and they're influencing this part of the world as well. In this part of the world, in Europe and other places, WFME and FAMR are also driving changes in curriculum. So I'd like to talk a bit about them. Now, why do I think it's important to integrate foundational science with clinical science? And I think one of the things that still rankles me is we put a session into a AAMC meeting, and one of the reviewers wrote, novel concept, but is this important? So what I'd like to do today is talk about why I think it's important and give you some ideas of how we've done it and some things that you can do. At the very end, I'll talk a little bit about the effects on faculty. We can talk more about that if you'd like. There's a number of literature studies that go to this, and I'll only mention a few. One of the very first studies about curricular integration really was initiated by the International Association of Medical Science Educators. At the time, maybe for some non-altruistic ideals, that the perceived reduction in time and focus on foundational sciences, so they felt they needed to speak up. But one thing that they pointed out, the people that wrote the article, sciences aren't just a compendium of facts, but it provides a framework. And it provides a framework for solving problems, and that they felt was incredibly important. Also, they felt that sciences should be studied early and often throughout the undergraduate medical education experience. So in the US, when we talk about undergraduate medical education, we talk about the MD degree, all right, which would be really talking about the latter stages of your MBBS. There's cognitive psychology that really backs a lot of this, and Nikki Woods has done an awful lot of this work. And there are several studies that have been published, but one of the things that really became important is if you can teach in an integrated fashion, in other words, link what you're talking about to a number of other things, people make more cognitive connections. It's much easier for them to pick up and understand the material. They don't memorize it, they actually know it. The other thing about it is that it stays with you longer. They actually have done studies that show that if you teach things in an integrated fashion, if you teach, for example, the idea of here's a set of symptoms, and they take one group and say, all right, here's some more medical stuff. They take another one and say, here's why the symptoms occur. If you do that, when they take the first test on some things, it turns out they both get about the same amount right, but if you wait a week or two, the group that understood why things were happening retains the information longer. The other thing that happens is it also makes it much easier for you to learn novel related content because you have a framework to put things in. This was all great. Then later work that Nikki Woods did, threw a bit of a monkey wrench into the works, as we say in the US, because what she found is simply putting things in proximity, what I would call an interdigitated curriculum, saying, all right, the cell biology course will be taught here in the biochemistry course, and we'll talk about this in biochemistry and something related in the cell biology course. This doesn't do any good. This is not true integration. It turns out that to really do integration properly, you have to do it literally minute by minute, and that's really difficult. And once again, they did studies, and they said, all right, for example, here's carbohydrate metabolism, and then we're saying, oh, now you know this, now we'll talk about a diabetic patient. And the students did it, and they learned and they forgot a certain amount. They took another group of students and said, all right, here's a diabetic patient. Now don't you want to understand what's causing this? They actually did worse than the ones that got the basic science first. Don't really understand why. But if you can teach it side by side, saying, this is what's going on, the diabetic patient, this is what happens, this is why they get the symptoms, they retain the material the longest and the best. So there's really good evidence and good reasons why you should do this. The other thing I'll point out is the students enjoy it much more. They'll learn more. Now, the US traditionally is a 4-year medical school curriculum, and this is what ours looked like before 2007. Very traditional curriculum. We had 2 years of foundational sciences, once again, and I'll talk more about this, but in siloed courses, a biochem course, cell biology course, immunology course, etc. We always incorporated a fair amount of clinical work, which is why I always talk about the pre-clerkship curriculum, not the preclinical, because there's no medical school in the world that only teaches the sciences without mentioning some of the clinical aspects that go with it. And we taught a fair amount of that. On the clinical side, a lot of clinical, and it was very hard for people like me to see any foundational sciences going along with it, which was a problem. Several other problems. To be honest, we were over-teaching the foundational sciences. So as a biochemist, I can say that. Back when I ran a biochem course, looking back, we taught 2.5 hours of the TCA cycle, the Krebs cycle, pushing every electron around. Yeah, I see some people nodding, a few people wincing out there. For the physicians in the room, I apologize. I had to learn all that stuff. I learned that metabolic map that had everything on it. That's what I had to learn. And I learned it in undergraduate, I learned it in graduate school. I didn't really learn it, I memorized it, which meant I forgot it shortly after. So we overtaught some, but the other problem was we weren't teaching in a way that made it easy for the students to access in the wards. So that if you teach the sciences in isolation, when they get in the wards, they can't go back to those sciences nearly as easily. So they had to kind of relearn the sciences, and that wasn't a good thing. The other problem was there was really literally a brick wall. That the clinicians weren't interested in talking to us, we couldn't talk back and forth. Nothing carried over from what we taught in the beginning and the end. And this was a very typical US curriculum. We've gone through 2 curricular changes since then, and this is what our new, what we call Curriculum 2.0 looks like. We've actually taken the lead nationally or internationally in that we have shortened the pre-clerkship phase. So for the basic scientists out there, don't worry too much. We went from 2 academic years, which was about 68 weeks, and I'll be happy to leave these slides behind if you guys want. But about 68 weeks to about 49 weeks of teaching basic sciences now, but we're also putting it back in later. So 1 year of foundational sciences going into then the classic clerkships, the rotations the students do in different departments. And then a 2-year phase, and I'll talk more about this later, called the Immersion Phase, where students are getting advanced clinical training, but they're also revisiting the foundational sciences in a meaningful way. A couple of longitudinal courses, Foundation of Healthcare Delivery, talk about the healthcare system. What is big in the US now is called system science, sort of how the healthcare system works. And then learning communities, which is really sort of the medical humanities, ethics, metacognition, leadership, and things like that. Now, before 2007, we had a very, very traditional curriculum. Discipline-based courses taught in complete isolation from one another. As I like to tell people, I taught biochemistry Monday, Wednesday, and Friday mornings. Anatomy came in and taught Tuesday and Thursdays. The only integration we had was before the year started, the person in charge of anatomy would send one of his underlings over to me and say, here's when our exams are, don't put yours too close. And that was the extent to which we talked to each other, right? Not only we did not talk, we didn't like each other because, of course, when they were studying for biochemistry, they weren't going to anatomy. When they were studying for anatomy, they weren't going to biochemistry. So there was an antagonism that really was unjustified but always there. So we didn't talk between courses, we didn't talk between years, mostly passive learning, most simply didactic lectures. The foundational sciences, all the social sciences, and the clinical were pretty much totally separated. We went to a first shot at an integrated curriculum in 2007, which we now refer to as Curriculum 1.0. The courses now were interdisciplinary. So we had a number of core courses for the first 2 years, interdisciplinary. That being said, and each one of those were highly integrated, but from course to course, we really didn't talk very much. Still didn't really cross-talk between years. Once again, mostly lecture-based. Curriculum 2.0 went to a pretty radical format in that totally interdisciplinary blocks. Individual blocks were extensively integrated, but more than that, all the blocks talked to each other. So we actually set up a curriculum saying, where should we teach blood? Where should we teach this? Where should we teach that? Horizontal, but also vertical. So, for example, in our learning communities, the block I teach, and I'll talk more about that in a minute, but the block that I teach talks a lot about genetics. So we were supposed to have a metacognition block to go with ours, and we said, you know, there's so many ethical issues that go with genetic testing now and DNA testing. They moved their schedule around so we could coordinate, so that we could bring up things in the foundational sciences courses, they could continue the conversation. A lot of active learning with small groups, about half small group. work, still didactic. We're not one of those schools that believes that lectures are bad and evil. I love when schools brag that we're not going to have lectures anymore starting in this year. They do have large group interactive sessions, which sounds a lot like my lectures, but they don't call them lectures anymore. And now everything is extensively integrated. All right. And there's sort of a continuum. If you see here, if you will, so this is sort of to show that we're teaching all the science and clinical stuff throughout time, but there really is a fuzziness to our curriculum in that, are you teaching something that's biochemistry, or is it really clinical, or is it really more cell biology? And the answer is we don't care. It's much more of a continuum now and flows back and forth more easily. This is a representation of the FMK phase, the Foundations of Medical Knowledge, which is the pre-clerkship phase. I co-direct it. I'll tell you about this in a second, but just to tell you about how we came about, the leadership team was myself, and I'm a researcher. I still have a laboratory and a biochemist, and I do a lot of educational work. All these people do a lot of educational work. But primarily I'm also a researcher. Kathy Pettifer is an anatomist, cell biology, 100% educational. Jim Atkinson is an MD, PhD, working anatomical pathologist, and Tyler Reimsizzle is pediatric neurogeneticist, strict clinician. So it was a very diverse group of 4 people that planned and developed and implemented the pre-clerkship phase. And this is really important. To the credit of our administration, they trusted the faculty. So the guardrails we had were really minimal. Now, there was oversight the whole way, and there were discussions, so they didn't just leave us on an island, but they fundamentally allowed the people who are going to teach the curriculum the opportunity to plan it. Now, the guardrails we started with, we had 49 teaching weeks. We actually have a 53-week curriculum, which is a not good number, but we managed to make it work. There's 1 week, we have the old first years and the new first years at the same time. We had 20 hours a week for the foundational science courses. We had to have prominent and consistent small group active learning across the phase, and we couldn't have more than 50% lectures. We had less than 50%. So if you think about that from an administrator's point of view, those are pretty minimal guardrails. What kind of small groups are going to be up to you, how you're going to plan this, how the blocks are going to be sequenced. But the one thing that we really wanted to have happen was to make sure that from block to block to block, the normal week looked more or less the same, the way we assessed was the same, to give this continuity across the curriculum. So if you stood back, all these individual blocks almost looked like one long course. And that's really important, because other schools will set it up so that every individual block can do whatever they want, and that's terrible for the students, because every few weeks they're changing radically the way they have to learn. Now, this is where things fill in, and once again, learning communities and foundation of healthcare delivery. This actually extends over to here now. There's also physical diagnosis, which you would probably call a doctoring course. And once again, that links up with what we do. When they learn about MS, multiple sclerosis, there are ocular issues, the problems with eyes. That's when they do eye exams, things like that. And cardiovascular, of course, that's when they're listening to hearts and things like that. So we start off with 1 week of sort of health system science, welcome to med school, big picture. We have 2 6-week blocks because we wanted to bring the students in a little bit quicker or a little easier, and then 3 12-week organ-based blocks. So Human Blueprint and Architecture is a course I co-direct. And this is the basic, more molecular aspects of medicine, but also we have to introduce the students to pharmacology, to physiology, to anatomy, and several other subjects. From there it goes into microbes and immunity, fairly self-explanatory. Homeostasis, which is cardiovascular, pulmonary, renal, and hematology. We call this EDR. We couldn't come up with a good name for it, to be honest, but it's endocrine, GI nutrition, and digestion and reproduction. Then brain behavior and movement, which is neurosciences, the extremities in terms of anatomy, which are always hard to figure out where to place in a curriculum, and psychiatry as well, neurology. Literally all disciplines occur in every block. So, I mean, almost some aspect of everything. So they're introduced to their anatomical donors in my block. They're doing things across the board. Every block has biochemistry in it and just essentially all the foundational sciences. Now, one of the things we decided we needed to do was go to more active learning. So this is one of our lecture halls. This is actually the lecture hall where the second years went, so it's a classic auditorium. The students are up there. You can stand behind a podium. You can be interactive, but it's not that easy. Even in our quote-unquote lectures now, we got away from this, and this is what our new lecture hall looks like. We converted 3 floors of our medical library because it turns out no one uses books anymore, right? You don't need them, right? No one uses journals anyway anymore. So it's more like a team-based learning classroom. There are 14 screens around the room. We actually had, the pointers are great because we use an electronic pointer. So if I point here in one screen, this dot goes in every screen. And it's really hard to, you can't make that room work by standing here and lecturing. The place, they were going to have the front of the room, it turned out there's a support pillar. There was no way to put it there. And so we have these little mobile podia that can move around, but it doesn't afford much protection. And to be honest, if you stand there, it's because we were the first people to start using this, and we realized if you stand there, what's happening is you've got students sitting at tables right over here, and they're facing this direction, and they don't know whether to look at you, and it's very disconcerting if you're a lecturer with a quarter of the students looking somewhere else. So what it turns out, the way the room works the best is the students look at whatever screen's in front of them. So you may be looking at a screen there, you may be looking at a screen here, and as a faculty member, you wander. And sometimes I'm in front of you, sometimes I'm behind you, sometimes I'm next to you. But it turns out it's an amazingly intimate setting, so even in a didactic lecture, it really allows for much easier conversation. And one of the things I found that was shocking to me, because we were the first ones to really use this room, when the students at the end of, okay. Nope, there we are. It comes and goes on occasion. At the end of my block, as I was talking to students coming out of the examination, I realized that I knew the names of at least twice as many students that I'd ever known in the past. We have 101 in our class. So, you know, you always know a few students, but I knew so many more, and this next year after we were used to the room, I knew maybe even more than that. All right, proximity effect. So the room actually, even that in the large group setting, it opens up things much easier. And also if you do things like team-based learning, we know about team-based learning? Yeah. So when you do things like team-based learning, this room works well. Virtual laboratories works beautifully. And like I said, even in lectures, we just spread the tables out a little bit more so you can wander a bit. All right, this is what a week looks like. So our students, it's a hard curriculum. Our students are in class for roughly 28 or 30 hours a week. One of the things we decided to do from day one is to treat them like young professionals, not just extended undergraduates. It takes them a while to get used to that because they're used to taking exams and then having 2 weeks off. In some blocks, you get done with exams on Friday, you start a new block on Monday. And this is the real world. I mean, I don't know about you, but I don't know a lot of physicians that go home at noon on Fridays. I don't know a lot of scientists that get to go home at noon Fridays. My class is over on Friday. I've got a grant due the following Monday. That's just life. So the science blocks are all morning, except for here where learning communities comes in. We get the afternoon slot. The learning communities are very good because, once again, things that we talk about during the week, they can continue here. Physical diagnosis or our doctoring course is the last thing on Friday, because if a medical student doesn't want to learn how to hear someone's heartbeat or learn how to pick up clinical skills, they're not worthy of being in med school anyway. So we can put that there. One afternoon a week, they're in a clinic. One afternoon a week, they are practicing their physical diagnosis skills. We always make sure we have these case-based learning groups I'll talk about in a minute. So they always get either Monday or Tuesday afternoon off to prepare for a case, or Wednesday and Thursday off to prepare for a case. Now, our case-based learning are really problem-based learning groups. It turns out problem-based learning groups over the years have taken some hits in terms of popularity. So in the US, everyone does problem-based learning, but we don't call it problem-based learning anymore. Slight difference here and there. Fundamentally, it's problem-based learning. Students come in, they get a case first thing. They move to the case, they don't know anything about it. Patient comes in, chief complaint, a little more information, the students talk, they write up their learning objectives, things like that. Goes through it all. Eventually, they come to a diagnosis for most of our cases. A few we don't, but for almost all of them, we do that. And then their job is to go home, look up, set the learning objectives, which really have to do very largely with the foundational sciences. You know, okay, why are you seeing these symptoms? How does this disease work? Things like that. What about the treatments? Some ethical or social issues may be also learning objectives. They come back and then explore it for 2 hours. So we have one case for an hour, second case for an hour, and then 2 hours to come back and 2 hours to come back. We were influenced by a lot of people. You don't have to reinvent the wheel. We actually went to our sister school at the University of Melbourne before the market crashed in 2000, and to understand about how they were doing things, and it really helped us a lot. Case Western Reserve also helped us a lot in terms of how to do these. Now, like I said, the case-based learning is really fun. It's 8 students, 1 faculty. And it's learner-centered, very active learning, and it simulates clinical practice, but in a very safe setting. So you really have a patient in front of you. It's a virtual patient on paper, but now you can talk about it and things like that. You really scaffold deep medical science, but in a very clinical setting. So this is an amazing way to integrate, because you're really talking about a patient, but you're really talking about the foundational sciences that go with things. Students can start to do diagnostic differentials and clinical reasoning skills, self-regulated learning skills. They work as teamwork, communication, leadership skills. And they also really are interested in understanding the material. This is also where, and I'll talk about this later in a slide or two, where we do competencies, things beyond the medical. We're integrating that way as well. So when we talk about integration, we usually are talking about integrating science with medicine, clinical work. But beyond that, we just came from a meeting, the APMEC meeting, where we were really talking about values. And we found a way to be able to teach foundational sciences and integrate these with the values we want in our physician at the same time, and I'll talk about that in a moment. What was really cool, this is a group I had, and this was a case on a fatty acid disorder, and everyone kept coming up adding these pathways. And what was remarkable to me is they weren't bringing any notes along. So the really interesting thing, I teach some metabolism now. I didn't used to. I tell people, I started teaching it again 3 years ago. I teach more molecular biology. Previously, before the last time I taught metabolism, I was a graduate student. I was a TA. I was a teaching assistant in graduate school. And one of our seminar speakers that year was Hans Krebs. So it was a very long time ago, Krebs as in the Krebs cycle. And I cannot tell you how many times, maybe you can appreciate this as any other biochemists in the room? Look at all the hands come up. I cannot tell you how many times I've been introduced to a physician as a biochemist, and they look at me and say, ooh, I hated biochemistry. Like, no offense, but I hated biochemistry. And what's amazing to me now is my students not only don't hate me for teaching them this, they actually really love the metabolism. And they love the metabolism because metabolism explains everything. Because they can explain everything that's going on in the case because of a block in one enzyme, and everything going on with the patient on the basis of metabolism, and that makes them really happy. Where they get frustrated when they get psychiatry, where you can't explain everything sometimes. At the end of the year, right? Some things in psychiatry, some forms of depression, we know exactly what's happening at the biochemistry level. We know that pharmacology works. But other things we don't really understand at all, so we can just treat symptoms. And that frustrates the students because they expect you to have all the answers. In metabolism, they get all the answers, so it actually makes them very happy. The other thing these are great for is they help to ease the transition to clinical phases, because they go through, I think, 74 cases a year, covering a wide variety of topics. And when they see patients, they can now relate back to the sciences very easily instead of saying, oh, there's metabolism here and there's a patient here. Now they understand how they intermix. And this goes for microbiology, this goes for cardiology, and anything else you want to teach. So it really works exceptionally well. And all of our facilitators and that work with our students adore the process. They all have fun with it, and they all come away. It's a very positive experience. Some schools only use physicians for this. Other schools, University of Melbourne, used fundamentally only PhDs. They didn't have enough PhDs, so they actually had a few physicians. We don't worry about that at all, because my job in this group is to facilitate. So when they look at me, having just given a carbohydrate metabolism lecture, and they look at me and say, Dr. Osheroff, is this right? I just look back and say, I'm just a stupid biochemist. What do I know about carbohydrate metabolism? What do you think? Because it's not my job to tell them the right answer. We have a problem with some of our physicians because they keep wanting to tell them the answers. The great thing about the PhDs, they often don't know enough clinical medicine to be able to tell them the answers. But what we do is we always give a facilitator's guide so you have some basics, you know where the students are supposed to be going and things like that. And these things work brilliantly. One other thing I'll point out, these also are really great because in the individual blocks, we all had to pick some things up that we didn't normally teach in our blocks. So people were happy to say, oh great, I think it'd be much better for blood to be in your block now. And it's like, and you're going, yay, I don't have to teach blood anymore. And someone comes by and says, oh, I think it'd be really good, skin would go better in your block than in mine. So all of a sudden you start picking things up that you weren't used to having in your blocks. So one of the things that we had to do, we picked up skin, and we also had to introduce our students to their anatomical donors, their cadavers. And this all happened in a week where we're doing signal transduction. And it's like, how do I throw this into a week in signal transduction when it's something so radically different and make it look real, look like it went together. And it turns out the cases are brilliant for this because one of our cases turned out to be a melanoma case. So now you have a skin cancer that's a BRAF mutation, so you've got signal transduction, but now it's in skin. So we're saying, all right, this patient has a problem in their skin, so maybe you guys need to know some things about skin. So all of a sudden now there's histology and pathology on skin. There's some laboratories on that. And at the end of the week, we introduce them to their anatomical donors, and they do a skin inspection. Similarly, they have to do a back dissection, because the problem with anatomy is you have to go in sort of a certain order, right? You can't do things until you've done other things. So they have to get through the back first. So, and that happens in microbiology. And so how do you do a back dissection in the middle of microbiology? They have a case of meningitis. You do a lumbar puncture. The students are so excited because they get to go down to their anatomical donors and do a lumbar puncture on them. And then they dissect the back. So you can take things that seemingly don't work together and make them work together brilliantly and integrate them even better by these CBL cases. Now, one other thing I'll point out is for you. She recognizes that. As small as that is, TCA cycle or Krebs cycle right there. I've taught about mitochondria. So oxidative phosphorylation. So we have fun. We start off the class. So I'll ask you, how many people breathed this morning? Raise your hand if you breathed. There's a lot of anaerobes in this room. Okay, not everyone's breathing. So you go to the students, you say, all right, why do you breathe? You know, like everyone does, so they kind of look at each other and go, and eventually they say, well, you need oxygen. Okay, great. Why do you need oxygen? Well, your brain needs oxygen. It's like, okay, why does your brain need oxygen? And eventually someone tells you it's the oxidative phosphorylation. You breathe to make ATP. Adenosine triphosphate is the energy currency of the cell. When the kid molecule goes to the dad molecule and says, Dad, I need some money to take this other molecule to the movies, he goes in his wallet and takes that ATP. It turns out that you only have a few seconds supply. So how long of ATP do you have? You can see it here. How long can you hold your breath? Now, if you're a synchronized swimmer, you can hold your breath for 4 or 5 minutes. Most of us, 30 seconds, 45 seconds, you feel it's burning. That's because you're running out of ATP. It turns out that on a daily basis, we all generate 50 to 75 kilograms of ATP. So you're generating your body weight in ATP every day. It's important stuff. But nonetheless, when we first started teaching this, we teach about ATP, we teach about Krebs cycle, we teach about oxidative phosphorylation, a little bit about mitochondria and what it looks like. And that was sort of taught in isolation. Now the lecture is on mitochondrial disease, and we still teach this, but now we talk about mitochondrial genome because that goes along with mitochondrial genetics, because mitochondrial genetics, how you inherit mitochondrial diseases, is very different than just Mendelian genetics, as long as the genes encoded by in the mitochondria. So we talk about mitochondrial diseases, we talk about things like heteroplasmy, genetic bottleneck, and all these other things around the context of a patient, all the ways that these mitochondrial diseases are really important and how they affect it. So even something like that with just straight up basic science, you can still really relate it back to a patient and really integrate it in a way that students enjoy. This is actually turns out to be one of my favorite lectures now. I actually did my graduate work in mitochondria, but hadn't thought about it for a very long time. Because this is one you say, well, what are the foundational sciences? And you kind of go, I don't really know. I mean, there's biochemistry in this, there's cell biology, there's genetics, there's molecular biology. There's all kinds of things in here. You can't really say, oh, this is the biochem lecture, or this is the genetics lecture. So there's all sorts of things that are in this one lecture, but because they need to understand mitochondrial diseases. Now, the other way we're integrating is, as I said, through values, and we'll call them competencies. And it's because it turns out, now, okay, start with the basics, I'm a biochemist. I will tell you that beyond medical knowledge, physicians have to know an awful lot to be good practicing physicians now. So in addition, they have to know medical knowledge, there's no doubt. But they have to have really good interpersonal skills, communication skills. They have to have professional values and attitudes and behaviors. When they walk into the room, they have to treat patients properly. You have to be competent about different cultures and how you have to interact with people differently from different cultural backgrounds. They have to be able to work in teams because medicine's now a team sport. They have to also be able to self-assess and improve their performance. And one of the problems we have in this day and age is how much medical knowledge there is out there. So they have to be lifelong learners, they have to be able to figure out where they are. There was a study done, and it was estimated in 1950, the medical knowledge in the world would double every 52 years. So none of you are that old, but if you had done your medical training in 1950, literally you could have been taught everything you need to know for a lot of the rest of your career. By the time it hit the 1880s, medical knowledge was doubling every 7-something years. 2010, every 3.2 years. And the estimate was way in the future this year, 2020, which turns out we just got into. The estimates were that medical knowledge in the world was going to double every 73 days. All right, my block lasts for, well, in terms of, well, okay, it would be 42 days. So, in the time my block is done, the beginning of med school, medical knowledge has already gone up substantially. So students have to be able to figure out where they are and be able to self-assess and be able to learn how to move forward. So we use competency domains. So we are, in addition to teaching medical knowledge, which is the first one here, medical knowledge or knowledge for practice, we are also training them in other areas. Professionalism, systems-based practice, which is how well do you play in a team. Practice-based learning and improvement, so how well do you take feedback and incorporate it and give feedback. Patient care and interpersonal and communication skills. These are the competencies that the Accreditation Council for Graduate Medical Education, or the ACGME, puts forth in the US for training what we would call residents, you probably call junior doctors, right? Similarly, the osteopaths in the US and Canada does this, and ACGME International, I think, is pushing these things as well throughout the world. Okay, monitoring our students in these areas and training them in these areas is good because they're going to be doing this later on anyway. But I think it becomes really important. And one of the things I'm incredibly proud of, and this is coming once again from a biochemist, that I think we're doing a great job teaching the foundational sciences, but we are also developing holistic young physicians while they're learning the foundational sciences. Traditionally, the pre-clerkship phase was the time where no one cared anything about you except for the grade you got in your science courses. And this wasn't the scientists doing this, promotion committees. So if you are getting 97s on your exams, but every day you walk into my class late, you walk right across the projector, and that nice shadow goes across, and the whole thing stops, and the entire class turns around and looks, and you kind of stop your lecture for a minute and let them sit down. And we tell the promotion committee, we were actually told one year we were gossiping about the students. It's fine, Neil, when they get in the awards, they'll be okay. And it turns out they're not. They're still oblivious when they're in the awards. The student that doesn't turn things in on time or doesn't answer your emails in time, the same people don't write their notes on time, don't get back to patients quickly either. So, and this is a whole lecture into itself, so we won't go into the real details of this. But one thing I will point out for the scientists in the room, that because they look at this and they go like, well, great. Here I am, and I'm teaching my biochemistry, and now that's this much of the grade, and there's professionalism, this, and now it's totally diluted, and it's not, because we consider each one of these separately. The point is that you have to have your knowledge, but if you're really, really smart, but you're also a jerk, pardon the term, it doesn't make up for the fact that you can't say, well, he's a jerk, but he's really smart, so he's going to be a great doctor. If you're wonderful and the patients love you and you have great communication skills, but you don't know your material, you're actually the most dangerous doctor out there, I think. Because when mom dies, I don't blame you for it, even though if you were incompetent, because you're a wonderful doctor and it must have just been her time. So these are all separate things and need to be dealt with separately. And we can talk more about that. The other thing is competencies, depending where you are in the world, people like or they don't like, because in many places in the world, they look at competencies as being competence. So there's 134 things you need to be competent in to graduate from this medical school. There are places in Australia like that. Deliver 2 babies, check. Be able to take a patient history, check. And so it breaks medicine down to very piecemeal bits, and it doesn't look holistically. And so it's not a good thing. We're using these as more of a GPS we talk about. It's a roadmap. And here's where you are, and here's where we want you to be. And by use of milestone languages, and like I said, we can talk about those, but what we're doing is we're developing you as a young professional. The other thing that's interesting is if you look at a competency-based curriculum, it's different from traditional curricula in that traditional ones say, here's the curriculum, here's our objectives, here's our assessment, maybe quality improvement. In a competency-based model, what you really do is say, what are the healthcare needs we have? So what it means is, what kind of physicians do we want to have? What do we want our graduates to look like? Then let's design a curriculum that will produce those kind of physicians. And so we wanted to change the physicians that we were making. We wanted more inquisitive. We wanted those that could do more lifelong learning. And in fact, we've done that. We're driving the clinicians crazy because the students are asking all these questions, thinking about things much more holistically, asking for feedback all the time. So we actually have changed this, and so you go through your quality improvement process, and things worked out pretty well. Now, competency-based assessment has some real successes, I think, because it turns out we always talk about assessment drives learning. It also drives development of behaviors and attitudes. Because once again, if you say, all right, here's where you are, and here's the next step in your progression, students, if you're assessing these things, students will learn from that. And they get assessed very much in these small groups, both by their faculty facilitators, but also there's peer. We do written peer feedback, and we actually do face-to-face peer feedback now, which works really well. It's allowed us to identify competency challenges, so issues in a very small amount of our students that previously we didn't see. We've been able to identify issues with some of our students now. Like I said, our students are great, your students are great, most medical students are great, but every class, there's 1 or 2 students and you go like, how did we let this student in, right? There's something about them. And we can identify challenges now, literally 2 or 3 weeks into med school, that we weren't seeing until the second clinical rotation in the 3rd year of med school in the previous curriculum. Much richer framework for predicting student successes and outcomes. So for promotion, it really works well. And the pre-clerkship faculty really like this because we've always had a stake in our students' development. We've always worked with them, but we weren't always taken seriously, and now we are, and we can do it in a very formal manner. There are certainly challenges that go with this. You have to have a lot of faculty and student development. In terms of the students, they have to buy into this. They have to understand the fact that we're doing this really, we are providing them with a roadmap to become a great young physician. And so it's really about coaching. Very few of our students, it's really about assessment, about pass or fail. It really comes down to, how can I make you better? And so some cultures don't like getting feedback. I had several people talking at APMEC would come up to me and say, well, our students, you can't go to a student and tell them there's anything wrong. They don't like it, and the faculty don't like doing this. And the first thing you have to do is just establish the fact that I'm not here to tell you what you're doing badly. I'm here to make you a great physician. So how are we going to do that? So you have to be working together. Faculty have to buy in because many feel that if I give you real feedback, it's going to damage your morale or put a black mark on your record, and these are very low-stake events, so it's okay. You have to convince block directors the data is real, because even those that were graded that way, if you will, as residents, don't necessarily believe it because they say, well, here's your test score, and you're telling me something else. You have to convince promotions committee. It's also think about the
promotion committee is like an example for the next stage.
Yeah, so these are the committees that say, yes, you're qualified to move on to the next phase of medical school. Pardon me. And having a digital platform to put it all together also is a really good thing. So we've been talking about putting integrating clinical sciences in the pre-clerkship phase. And to be honest, a lot of schools do that one way or another. Putting sciences back into the post-clerkship curriculum when they're in their clinical, after clinical rotations has been a challenge at most US med schools. And so what I want to do is talk about how we do this, the immersion phase. So after they have gone through the science blocks, they go through 1 year of the classic rotations through medical departments. And then the last 2 years we call the immersion phase, and that's what I want to talk about. Each rotation or block is 1 month long. We give them 20 months, 15 are required. They have some time to study for their board examinations. They have time to go interview. They have time for holiday, things like that. For IC, I'll talk about IC, what these are in a second. They have some research to go in here, and the longitudinal elements continue. The great thing about this is kind of what it looks like, and it was meant to be a highly individualized 2-year phase. In fact, students love it. The only person in our university that hates it is our registrar, because we've had now 3 classes go fully through the last 2 years, and no 2 students have taken the same curriculum. Not only have no 2 students taken the same course, this course followed by this, I think no 2 students have actually taken the same exact combination of courses. And to their credit, our administration, the top goal was to really deepen foundational science knowledge during meaningful clinical engagement. Now, once again, we're not talking about pulling students out and saying, here, we know these pathways. It's like, why is your patient sick? How these drugs that you're going to give your patient work. All the things that you want to have your doctor to know. And of course, you want to solidify their clinical skills and all these other things that go along with preparing them to become a junior doctor. I told you we had cut down on the time we taught foundational sciences in the beginning. This is where we put some of it back. And they have what are called integrated science courses. These are month-long. They have to take at least 4 of these, and these are what I want to talk to you about. The integrated science courses are really amazing courses, and these are really unique. They are teaching foundational science, but you have to have meaningful clinical engagement. This is not a classroom experience. This is really, you're seeing patients and you're learning the science that goes along with those patients. Students spend about 50 hours a week in these because they're on call, they're on weekend duty taking care of patients, things like that. We use multiple modes of instruction, but it's usually very active learning. These courses can have anywhere from 3 or 4 students up to maybe 24. Small to the small. Each core learning objective, other than just clinical skills, really need to have some science component. Once again, what's the science behind what you're doing? And assessment of foundational science knowledge is really important in these. So this is for real. This isn't just in name only. And once again, it has to be done, but if I come in and say, I want to have this great biochemistry course, it's not going to fly. It really has to be in meaningful clinical engagement. We have a menu that students can choose from. They have to take 4. So you have things like cardiovascular diseases. Community healthcare deals with foundational sciences, but the more social sciences. So there's a variety of things, not like all biochemistry. Emergency care, but diabetes it has a lot of molecular sciences to it. Emergency care, physician put a phenomenal course together that has a lot of anatomy. It has toxicology, pharmacology. The course is sort of based on what if an unconscious patient. Most of these courses have both an MD and a PhD that kind of co-direct, but this is one where emergency medicine at Vanderbilt has always been a very strong teaching department and a department that really thought about what they were doing. 2 physicians are running this course and they're doing a brilliant job, so there's no chauvinism as to who can or can't run these. Getting hooked, if we talk about addiction now, opioids in the US are a very dire issue. And across, so you have infectious diseases, you have ones that really relate to more anatomy. Things like sexual medicine and reproductive health have a lot of endocrinology, they have a lot of anatomy. So there's a variety of things you can take. I'm just going to talk really kind of briefly on clinical cancer medicine. Now, one problem is I can't sit there and say this is what a course looks like, because they're all different. But you know it when you see it. And once again, they're seeing patients while they're learning these materials. So, for example, you set personal learning goals. They're meet the experts. They bring in oncologists to talk, but they're online modules. They do their case-based learning, so they're doing sort of cases. There's team-based learning. clinical experience, doing patient encounters, they're going to tumor boards, they're writing clinical essays, burning questions, so they have to research some things. Okay, tell me something that you've seen. You need to go write, research it and come back and tell me about it. And once again, these are done while you're seeing patients. Now, one of the cool things about this, we can also tailor this. The immersion phase, they did a cloud diagram of things that people thought they wanted to do, and medicine was big and surgery was big, but undecided was equally big. So with these, there's such a variety of courses you can take. If you don't know what you want to do, you can experiment and look at a lot of things. And we have yet to have a student that didn't go into the match because they couldn't figure out what they wanted to be when they grew up. They eventually find out. But by the same token, if you know what you want to do, we can tailor things. So you want to be a surgeon. So, okay, in this course, we'll put you in a clinic that is probably a breast cancer clinic because there's a lot of surgery that goes along with that. If you want to be in internal medicine, we'll put you in a hem-onc clinic. So there are ways we can tailor even within these courses. It turns out students actually love these courses. We get lots of comments and hands down the best class I've ever taken in my life. Usually that's accompanied with the hardest course I've ever taken in my life, but oh my God, everyone needs to take it. And so this is just a variety I pulled, and these are 5-point Likert scales. So overall learning experience, I mean, if you look at these numbers, especially from a scientist's point of view, those are amazing numbers. Motivated me to keep learning the area, contributed to professional development, helped me learn relevant sciences, pretty good. Anticipating using the sciences they learn later on. Recommend this course to my peers. So these courses have gone over exceptionally well with our students. And once again, this is like if you're a scientist, this is the holy grail. I teach some things that I work with a target for a lot of anti-cancer drugs. And I'll tell you, I had a day when I had one of my medical students who had testicular cancer, and he was being infused by a drug called the topicide that I work with. And one of my own students had a synovial sarcoma, and was the next room being infused with doxorubicin, another anti-cancer drug I work with. And you have a much different feel for these drugs when you're talking to a patient that's being infused with them than when you're in a laboratory working with them. So this is really, this experience really sticks with the students. And once again, they learn the materials really well. There are challenges that go with it. It's very successful. First is maintaining scientific rigor. When this was first proposed, they came to me and said, Neil, look over these. And some were amazing, and some, I used the word devoid, because they didn't seem to have any, I couldn't see where the sciences were. So there's a group of us called Master Science Teachers. All of us were trained as bench scientists. There's 6 of us now. Most of us teach heavily in the first year. Some teach in the later years. And we review all these courses. So they come with initial concepts. They come and we review it. So we're assessing, but we're also helping them. We're giving them ideas. We're talking about people. We're telling them, okay, this is what we've already taught in this area. This would be a great thing to do. And eventually they come up with a proposal, and then we review these courses every year. So to help, and that really has been important for maintaining the rigor. And to be honest, our administration has been great in backing us on this. So it's one of those things that PhDs worry that the MDs are going to say, oh, I don't need that, but they've really been very supportive of this. And once again, it's not science for the sake of saying we're learning science. This is the science that underlies the things going on with your patient, which I think you would all agree are really important. So, just getting faculty participation, things like that, the usual kind of things, but a lot of faculty development goes into this. And then course capacity from a registrar's point of view, it's a nightmare, but it works out really well for us. All right, so let me just talk briefly at the end, successes that I think have happened. In the pre-clerkship phase, this is by curricular, because of curricular integration. We're now teaching in a more holistic style. We're not bounded by disciplines anymore, which is great, which means I don't have to say, oh, look, you're a biochemist, you're allowed to talk about this. You can't talk about this because this is physiology, right? We talk about it where we think it's important to talk about it. And it really emphasizes the clinically relevant biomedical science material in the context of the patient, which is, I think, really critical. Students now see the information as being really relevant. So they, quote unquote, know the material. They don't tend to memorize it. So memorization is something, you go, you memorize all the stuff, you tend to forget it. And we didn't have time to talk about it, but the way we assess them, we do things in a more holistic fashion that goes along with this. The students now have an easier time translating what they've learned, the sciences, to patients. which is also critical because then it gets them moving on the wards much more rapidly and it makes better physicians to make better decisions. And they also have a greater interest in understanding, and they're more inquisitive, which drives our physicians a little bit crazy because students are asking them a lot more questions now, which is a good thing. It took us about 2 or 3 years to retrain our physicians because we're training our students to think, how would I manage this patient? And the physician's saying, all right, tell me all the bones in the feet, right? And the students go, wow, okay, but what does that have to do with this? In the clinical years, I think it's also been important because students now have a better understanding for the underlying basis for human disease and treatment, which is exactly what we want. They see the foundational sciences as more relevant in their careers and lifelong learning. And with the use of competencies, I think we're actually creating higher quality physicians. One of the things we got back from physicians are that, especially the ones that you teach way too much science, then we said, great, we're going to go 1 year of pre-clerkship. They said, how can you possibly give me a student after only 1 year of med school? And it turns out the students we're putting into the clinics now, I think are actually more mature and they're equally good as the students that we did in their old curriculum. So to be honest, at the end of 2 years now in our curriculum, our students are where they used to be at the end of 3 years, but I think they're even more mature at the end of 2. So it's been very successful, we think, from our point of view. What about faculty? Let me talk about faculty for just a little bit. Faculty is, and I'll talk from the point of view of the pre-clerkship faculty, the basic scientists, but you can put this in different ways. Curricular integration really plays with your identity. I'm a biochemist. I give really great biochemistry lectures. And now you're telling me I'm in a course that's not called biochemistry anymore. I'm not really controlling it as well as I used to in terms of what's in there. You want me to teach fewer lectures. You want me to do some facilitation, other things. And it really worries them. And this is one of the reasons why, for those of you doing curricular revision, when you come and say, oh, my basic scientists have their heels dig on, they don't want to do any of this, these are the reasons why. And you have to understand these are real issues because you're messing with who I am. And so you have to be able to help them over that. And I'll tell you why in a minute, why it works so well. Several things that are really great happen. You get new relationships, cross-disciplinary. So Kathy Pettifer, for any of you who have gone to some meetings, we're sort of joined to the hip at a lot of meetings. We present a lot of things together. She's an anatomist. We didn't even know each other before we started doing this, and we've been now working together, co-directing courses for the last 10 years. So you get to talk to both physicians and scientists in a different way. You get new skill sets, because now I understand more about how to facilitate. I do much better with feedback, which I then apply in my own laboratory, and I do a much better job with feedback to my own students. Mentoring and coaching come along with a lot of these things. So I am a more holistic science educator or researcher than I was before I started this. Faculty, the position in the department may change some, because all of a sudden we used to have a biochemistry course, now we don't have a biochemistry course anymore. So very often your worth to the department may diminish because your chair is saying, well, I don't care about this course anymore, so why are you important to the department? But it turns out that your importance to the institution grows dramatically because our administration figured out who are the people that really are teaching their students. And you're now the banner bearers for your discipline. Also, they're much greater, and this is where it really is interesting, much greater opportunities for professional development. So I understand about curricular design now. Leadership, tons of leadership opportunities. Before you ran your course, now I was one of the people that implemented our pre-clerkship phase. I co-direct the phase. I chair our master science teachers. I direct our Academy for Excellence in Education, and that's at Vanderbilt. I'm a past president of a biochemistry educators group, and I'm the current president, as I said before, of the International Association for Medical Science Educators. All because of curricular revision. Historically, if you're teaching, they know who you are in that school. But historically, they didn't know where you were anywhere else. And for basic scientists, if you didn't have a laboratory, you weren't really much of any interest in the department. Now you can have this really rich career that you can be known internationally for your educational efforts. And that's one of the things to convey to scientists or even clinicians that are getting into educational work, that you can have this amazing career. Okay, I go to places like Asia and places like Malaysia to talk about my science. But for me to think, I am standing in front of a group of smart, important people in Malaysia to talk about my educational efforts, X thousand kilometers away from home, that's pretty remarkable, and that's all because of the curricular revision. a lot more scholarship, and the thing is networking and recognition is great. And the other thing I point out, there's a wonderful quote by Sun Tzu from The Art of War that says, in the midst of chaos, there is also opportunity. And trust me, curricular revision is chaos. So you have the opportunity, instead of saying, I won't do this, if you say, all right, how can we make this work? You can emerge as a leader, and you can emerge as someone that really takes control of the situation. So it's really important. Very last thing I'm telling you, and this is even thinking more holistically, that maybe the time has come to stop worrying about what are basic science, foundational sciences, and clinical medicine. I think it's all biomedical sciences. I may emphasize more bio, you may emphasize more medical, but it's a continuum, and I think we need to look at it that way. There's no brick wall. This is what's going on. And the other thing is, we don't have to call it, like, when we get into later years, people put science back in later years because they have a capstone course. They pull students away from patients, they put them in a room, they show them the Krebs cycle again, they hate it, right? So you have to incorporate it. But for me, it comes down to this. We don't have to call this science. Go to one of your students in their later years, or a junior doctor, or even your physician, and say, okay, why is this patient sick? Tell me what's really going on. What's really going on in this condition? Why are they showing their symptoms, right? Why is this person coughing? Why does this person have high blood pressure? Whatever it is, explain it to me, what's actually happening. Tell me about how you're treating them and why this is going to make them better. Not just, oh yes, we treat with this drug and they get better. Why are you getting better? And how the drugs that you're using work. If you can give a student, or to be honest, I'm not sure if my attending physician can do this as well, the person like my internist, but if you can go to one of your students and you can ask these questions and get great answers back, first you have a phenomenal physician that you're making, but more importantly, they're going to be a great doctor and they know a ton of science, because every answer to every one of these is what I would consider foundational sciences. So, if we just think of it as this continuum, it's not a them and us, it's one thing, I think it works much better. So with that, I will say thank you for your time. We've written some papers on some of the things that we do in the pre-clerkship phase, and these integrated science courses I'm more than willing to share with you, and anything you want to talk about. So thank you very much. Running a minute.
Open to some questions. Yep. Any questions from colleagues?
How much more resource intensive is your new curriculum?
Ours
You
is
talked about the successes, but maybe we could hear some of the challenges. You mentioned some of them in passing.
yeah.
I'm sure the negotiations between the scientists and clinicians would have been quite difficult.
Vanderbilt, we have a pretty collegial faculty, but yeah, there's tension early on. I won't deny it. Resources, there's more financial resources because we actually pay our small group facilitators. Many schools don't. But we wanted to have a trained cadre of individuals, and you take an emeritus faculty and give them a Starbucks gift card for having done it. You can't control anything that they do. We went through 2 curricular revisions. Our curriculum right now is fairly radical, and it's actually a model that's being copied by a number of schools. You have 7 or 80 schools come visit us, and in one way, shape, or form, we're influencing a lot of people. We could not have done that starting. I've talked with my senior associate. This is one of the things we're going to talk about at our little meeting we're having. I guess I should have put a picture of it up, but that we couldn't have gone from siloed biochemistry and pharmacology courses to what we have now. So the first step in our first curricular revision was the scientists started working in an integrated fashion. And that, just moving from siloed courses to integrated curriculum, is incredibly difficult for the reasons I talked about. That you're messing with people's identities. And I don't mean that in a trivial fashion. Is this who I am? And now you're coming to me and you're telling me that that's not of value anymore, or that I can't do that anymore, and I don't see what I'm going to be when I come out of it. That's why I talk about some of the successes, my own personal successes. That there's a ton of ways that not only can you teach your students better, but you can have a much better career. So those definitely, some of the IT that went with this was really important for us to manage things. But the reality of it is you can do a lot of these things without having to worry about any of that. You can really do a lot. I think the really important thing is to get the faculty talking with one another. One of the things at Vanderbilt we came to recognize was the fact that we don't worry about whether you're a clinical faculty or basic science faculty anymore, and we used to. 20 years ago was quote unquote them and us, and oh, you PhDs, you know, kind of a thing. And they say, oh, you're teaching too many sciences, and I say to you, well, maybe if you knew some more science, you'd be a better doctor, and we go back and forth and forth and back. You know, I've had physicians that tell me if they knew more, they wouldn't be a better doctor, and I'm thinking like, how can that possibly be? But okay. So you know, we had days like that, and we tried. A lot of this goes back to my senior associate dean, who was just one of those people. She had a pillow in her office that's embroidered on it was "Play nice or leave," and it wasn't that she forced anything. It was just somehow the way she modeled that really helped. And you need a few champions. You need a few people that are willing to try doing this and that have some status in your university. You know, senior leaders that. Well, if this person is willing to do it, then who am I to say I can't? So, and you have to get over those humps. Because I said, I think one of the important things is to convince faculty that this is a better way for students to learn. There'll be better physicians, and that you'll have more fun doing it, and you'll be better for it. So one of the things we always tell people, and this people told us, if you have doubters, come visit Vanderbilt. We'll show you what these groups look like. And we were told with Case Western Reserve, send us your biggest doubters. Send us the people that are going to be kick their heels in the most. And they show up and they're watching the students and they're going through things and they're excited about the sciences they're learning, and you're going like, this is amazing. And it turns out you can learn things when I'm not lecturing to you. Okay? There's a balance between what you need to have in lectures and what you need to have in the cases. So I mean, there are certainly obstacles, but on the whole, it can work really well.
Coming back to what Professor said about the resources, because I know even your small classes was 1 to 8. So, which means because you're having 2 cases, I saw for the early years, 2 cases, and then that means you would have 100, you said you have 100 students.
So we have 12 groups.
12 groups. So 12 groups times 2 because it's 2 cases.
No. I have you for both cases. Keep in mind, I'm not a content expert. We don't keep switching facilitators. So I have one group of students for 12 weeks. They get 5% effort, which is about right. They're with their students for 6 hours a week. There's like an hour debriefing, and they have to do a little bit grading. So it's about 8 to 10 hours a week commitment.
The hours, meaning if you do 2, so you do 12 times 2 because there are 2 cases a week.
Yeah, we do like 74 cases a year.
Exactly. Which means the faculty role has really shifted from taking the classes to really doing this.
In part. And I wrote one of the cases. I mean, it's usually clinicians that write the cases. I wrote one on acetaminophen toxicity. It was actually one of my own students. The pathologist asked me to get medical records, so he got the medical records, and I had to sit there and start reading medical records and figure them out. And they're really fun to figure out.
So the ISC that you talk about the other way around,
Yeah.
integrating the other side, given that isn't the clinical training quite distributed, and then how do you get the students?
Well, keep in mind, at that point, they're in one block. So in other words, it's not like I'm pulling you out of something else. So I've got you for a month. And from a registrar's point of view, it was really difficult because, and like I said, the registrar doesn't like us at all. And some of these are as big as 24 to 25 students. Some are as small as 2 or 3. And they're all.
Having various ISCs running at the same time. Right?
Oh yeah, every month there's 8, 10, 12 of them running. And so those are logistic issues, but they're overcomable. They're certainly overcomable. But keep in mind, we didn't start that in the first go around. So if you can move from, depending what you're doing, something having a little more active learning. And once again, we're not what I call a BL school. There are places to go all over the world, especially in the U.S. There's no way students learn anything as well as they learn in PBL. No, there's no way they learn anything is better than TBL. They know there's whatever it is over here. And we don't believe that at all. Every one of these learning modalities has strengths and weaknesses. So we are not wedded to any of them. But the cases go throughout, so you have to have things that look consistent. Other schools that I've seen that say, all right, in return for teaching in an integrated fashion, you teach cardiology any way you want. So I went to a school and it was like, these guys have all these little groups. Then I have mine, and I have another kind of group. And these modules went 1 to 3 weeks long, so every few weeks the students are relearning everything. Someone else likes middle size. And then you get the guy that ran the neurology clerkship that also was teaching the neurosciences. And he said, you can't possibly learn enough neurology in these small groups over that period of time. He gives them 22 hours of lecture a week. So, you know, these students are going crazy because they're taking high-stakes exams every 1 to 3 weeks, and every week they're changing totally how they're supposed to be learning. And so there are things like that. There are a lot of stressors on the students. You know, we put students under pressure. I'm sure your students are stressed. Because if your students aren't stressed, you don't have a very good med school, right? Every medical school in the world pushes the students. But what we try to do is get rid of the unnecessary stressors. And that's an incredibly unnecessary stressor. So, yeah, I mean, look, I'm not going to tell you that, oh, we just walk into a room one day and say, you know, as a dean or whatever, you walk in the room and say, we're integrating our curriculum, goodbye. Trust me. My dean did that the first time. The very first curricular revision, he basically showed up, gave us a quote by the head of the AAMC, who the scientists had never heard of, a quote by a guy named David Irby, who's like the god, he's the new Flexner. We'd never heard of him, of course. Left us with the, and a few other quotes, left us with the impression we weren't doing a very good job, walked out of the room. And for the next 6 months, the entire faculty went, why are we doing this? I don't want to do this. And he set us back literally 6 months because of the way he handled it. Instead of going and saying, look, this is a trend. It turns out we're going to have to do this in the future. It's a better way for students to learn. You guys are doing a great job now, but we can do this better. I need you to help me because we're being forced really by eventually outside pressures are going to force us to do this. I need your help. We can work together and we can do this. We would have moved forward much more quickly. So I mean, I've watched this. One of the things we'll talk about at the meeting, I've watched, you know, we're going to talk about a lot of our mistakes.
So what he refers to, the meeting that is the IMC Asia meeting that's happening one day before the Ottawa conference. We have a lot of colleagues from School of Medicine here and other schools, of course, but please, any questions?
And if people here sign up, we'll give them the early bird. Yeah, we'll give you early break because it's not in there now because Bishop was saying they've got some people that want to come, but we don't see an early bird rate anymore. So if anyone wants to come, we'll give you the earlier rate, which is less money.
Shahid first. Yep.
I saw in your framework, mostly your curriculum delivery is the more teaching learning is case-based learning, right?
6 hours a week. Out of 20 hours of science, 6 hours a week are the case-based.
So case-based learning, I know it's a suitable mode of learning for in clinical setting, but your PBL, you know more practice PBL, right?
Well, it's PBL. It's essentially PBL.
Your layout is a PBL. I saw the classroom arrangement, the layout is more of a PBL. So do you use PBL as well, or those are used for introductory lectures?
We have small breakout rooms that we use for PBL. It depends. TBL comes and goes. We use it to teach genetics, which is also, it's a really fun format. TBL is a great format if you want to have small group engagement, but you don't have a lot of facilitators, because literally one person, I can facilitate a room of 100 people. So from that point of view, once again, the kind of small groups you use aren't so important as having the students in the active learning and engagement. Yeah, so, but our classroom now looks like a TBL-based room. So that
Lectures are in the TB, looks like a TBL. That's what he
yeah, yeah. So if I were lecturing, you guys would be you know, take these two tables, move them together, you'd be sitting there, and I'd just be wandering around the whole time, which makes it's interesting when you lecture because you can't stand it with notes. When I give a seminar, I don't use notes, but you know, when you're giving 6 hours of lecture in a week, you can't memorize everything. It's nice to have some notes in front of you. Walking around the room, you can't do that. Also, you feel very exposed. You know, people, especially what we call the one-off, the clinical lecturers that come and give their lecture and leave, like to have something here that I can look at, and you're out there, and now you're kind of walking around in there, and you feel very exposed. But it creates a much more intimate relationship with the students. Those of us that teach a lot, it's really been fun. It's been fascinating, but it really has changed the interactions in a very positive way.
I was just wondering what it would take to prepare the facilitators or train the facilitators to do those sessions effectively.
Yep.
I mean, to engage the students, not just to deliver the session, but also to carry out the assessment. So I guess there's a special set of skills needed to do that.
We definitely do faculty development, and we work with you. We also put, you know, what we try to do is so we talk about the format and why we're doing what we're doing and things you should do. In other words, you're not there to answer their questions, which is really hard. especially when you're watching them talking about something way off base. And one of the greatest pieces of advice I got from someone that was more senior than I was in this said, just when you can't stand it anymore and you have to say something, wait for one more person to talk, and invariably a student say, the goal of the case was this. I think we need to go back to the immunology, and we need to not talk about this. And you can do that too. You can certainly direct them. You can say, all right, guys, keep in mind that you're going to be getting a pulmonary block, so we don't really need to talk about a lot of lung physiology here. Why don't we bring it back over here? And so we just do that, and we let you sit in, and usually with the new people, we have someone more senior that might sit with them for the first few cases just to help them get going. They adapt to it pretty quickly, but you absolutely have to have faculty development, and we have to have development with our students to explain how the first hour when we do this, it's like how these work, what do we have to do, what are the different roles that you have, what are the absolutes, these meet at the same time every week. You can't come as a group and say, oh, we want to study for this exam, and oh, can we do this at Thursday night instead? No, they all have to be done the same way, and things like that. But faculty development works. I mean, you can do that. It's okay.
But I think one of the points here was the integration, right? And we just reviewed our curriculum, and to me, the take-home was also bringing the basics or the sciences into the clinical years,
Yeah.
right? That was also a stark difference now here, which perhaps when we were reviewing, we were so focused on bringing clinical sciences into the
Yeah.
early years, but not really thinking the other way around. Any thoughts on this, or? Because one of the challenge we had is we wanted to bring health system science, and I think the colleagues have done quite well in integrating that, but also bringing care from hospital-based to learning to community-based in the later years.
Mm-hmm.
But that, of course, had some difficulties because the traditional specialties in the clinical years were thinking, oh, my weeks, I'm going to lose some of my weeks,
Yeah.
and it put people up in arms. So maybe you can answer this question. How about community care? Because how was that addressed? Or in US, is that the trend from hospital beds to community care?
We actually have one of our ISCs is community health care. So yeah, that's one thing that we suffer from, and most U.S. medical schools suffer from, that most of the clinical experience are hospital-based, not community-based. But like I said, we do have one of the ISCs that really talks about that. So students that really want to go into family medicine and rural medicine, things like that, really always gravitate to that one.
Is that because the role of community care is now increasingly taken up by these nurse practitioners and others, or the role of the doctor in the community is?
I think it's just hard to control. The people that are our faculty at Vanderbilt, we can work with. When you out in the community, you're working with sort of people that you have to bring in, and they may not understand the way you're doing things, and it's much harder to get consistency across those domains. I think putting things back in later years is really important, but it's something that's really been a challenge in the U.S. But it's coming. It's just like longitudinal clerkships are starting to pop up in the U.S. So now,
With Australia, I think, yeah.
and it's happening in a number of schools, and so the idea behind that is that instead of saying, okay, you're in medicine for this 6 weeks, and now you're on neuro, it's just I have a group of 8 students, and I make sure that they get the proper experience throughout. Very difficult way to do it. The people that are doing it find it inordinately successful because, once again, you're thinking much more integrated. Because now my patient that had a stroke is going to rehab, and they're going here, and I'm following the whole way instead of just cutting it off. But that also will be very difficult. Part of the challenge you have in clinical years, and if anyone is a clinical chair here, I apologize, is that the clinical chairs really control those environments. Whereas ultimately the basic sciences, when you go to integrated curriculum, it goes away from the basic science chairs. So it's more centrally done. And once it gets away from them for a couple of years, they kind of forget about it. And so I don't have to worry about my chair coming to me saying, oh, Neil, I need you to put this person in your course because they lost their grants, I need to have them do something. or this person needed more teaching for tenure, so they have to lecture, and I know these are terrible lectures, and I want them in my course. So, you know, and it also means that I don't have all biochemists in my course. You know, because in this day and age, it's hard to tell what a biochemist is versus a pharmacologist. I mean, I do a lot of pharmacology, I can do microbiology, so that you now find the best people. And the best person, the person that used to teach metabolism in my block was a pediatric geneticist. So, because every patient that came into Vanderbilt Hospital with an inborn error of metabolism was his patient. So he knew metabolism really well. Traditionally, we allow an MD to teach metabolism. Are you crazy? But you know, you don't care anymore, right? They have the skill sets. So once again, I think we just have to forget about some of the boundaries. And that's really hard. That's really hard.
This is about our time. We were taught with a very discipline-based curriculum, where anatomy, physiology, and all was taught in detail. But with coming out this integration and immersion phases and all, the clinical, the focus on clinical sciences has always ended up with the students carrying with little knowledge in basic sciences and anticancer. And this is always the complaint of the clinicians when they come to the clinical phase, that the students' knowledge in anatomy and physiology is not up to the mark. That has always been there.
Okay.
So do you find the similar complaints in your curriculum delivery, or clinicians are happy with it? Because the case-based learning or PBL and all definitely have less emphasis on anatomy as the discipline. So how do you overcome this to students to have the required knowledge of the basic sciences?
Okay, first, once again, it's 6 hours a week. It's not the entire curriculum. Second, a lot of our cases are really heavily based in anatomy. I mean, when they do brain behavior and movement, there's a ton of anatomy that they're learning. And they're going to dissection. We still do cadaveric dissections, things like that. People are moving away from anatomy because it's so expensive, and they don't want to do cadavers. Case Western Reserve is going to almost all virtual anatomy now. I don't know if I like that or not. We'll see how it works. The other thing that we've come to understand is that U.S. med schools used to be designed to put out what I call a totipotent physician. You're there, you know everything that any physician could know, so you could go into any discipline you wanted. And we're realizing that doesn't work that well anymore. That indeed, that depending on what your discipline is, you need to know, if you're a surgeon, if you're an orthopedic surgeon, whatever, you need to know a ton of anatomy. Others, not so much. If you're an endocrinologist, you know a lot of biochemistry. A surgeon, not as much. And so the real thing is, what do all physicians need to know? And that's an argument that no one can quite answer, but we all try. So in ours, it's still, you know, in the 53 weeks we have them, is very intensive. And they learn an unbelievable amount of foundational sciences. But we still recognize the fact that it's a 4-year curriculum. That you don't have to know everything, every anatomy you have to know at the end of year 1. So that it may be that you have to teach a little bit more later on. And so that's also part of it. That just as we don't save all the clinical for the end, we don't just do the sciences here. So it really is a 4-year curriculum now.
Just asking, how was your USMLE Step 1 and Step 2 scores,
Sure.
given the 3 different phases of curriculum? Because you're more and more integrated, what
Yep.
impact did it have on the scores?
Yeah, because one of the things about curriculum is no matter how good your curriculum is, if your USMLE scores plummet, it's a terrible curriculum.
Yeah.
So University of Alabama at Birmingham, at the time, was the 17th ranked medical school. When they went to their first curricular revision, they did not do a very good job. And when they came up in their step scores the first time, they had the 14th worst in the previous 15th year, and they'd failed 13%, right? This is the 17th ranked med school in the country. Disaster. When we went to our first curricular revision, we had the highest board scores in our history. We went to the second curricular revision. The first year, we tied for the highest board scores in our history, and every year since, the board scores have moved up. So they don't publish board scores in the U.S. Unfortunately, you can't say where do you rank. Vanderbilt is probably among the top 1 or 2% in the country. I mean,
But you would know your own scores, your
Yeah.
own students' performance, right?
yeah. So ours have done spectacularly well.
So maybe that might answer also, because for the clinical years, after your Step 1 results seems to be at the top, and you know they are doing continuously well, then I know there's a lot of arguments about the USMLE Step 1 and the kind
Yeah.
of questions and the focus on it, you know, but I think that's one testament, I suppose,
Yeah.
for the knowledge and application of your basic sciences.
Yeah, so that so they're definitely learning them. And we're not teaching as much science as we used to because we realized, once again, you as a physician probably don't need to be able to push every electron around the TCA cycle. And you guys will laugh, but an obstetrician probably doesn't need to remember all the bones in the feet. And so it turns out we were teaching more than we should. Now, I think we still need to teach more than physicians think they need to know because you never know what you need to know. So we're teaching a bit less, but trying to teach it in a more appropriate manner with the understanding that if you're going to be a hand surgeon, you're going to learn the anatomy of the hand when you're a resident. You're going to learn that in exquisite detail. Every bone, every tendon, every blood vessel, every nerve, and you're going to know it vastly better than any student coming out of medical school, right? So once again, it's a continuum. It's a continuum of practice. And I think that's not inappropriate. And I can say the same about biochemistry, right? Maybe you're not teaching as much. We're not teaching, definitely not as much biochemistry as we used to, but we're teaching enough. And if you want to use it in your practice like you do in ISC, they'll go much more in depth in those areas now. It's the same way research has been for years, that we, as a physician, you know a lot about potentially a small area. I mean, general family practice, maybe it's different, but if you're a specialist, you understand this. But, when you're on the airplane and someone says, do we have a physician because we have a woman that just went into labor? You're not real keen on volunteering to go up and deliver that baby. Most
Especially, you know what his specialty is?
ENT, right? So yeah, you definitely, unless it's coming out this way, you don't want to have anything to do with that baby. That's why I don't like to make reservations under doctor.
I can let the child breathe per nose, huh?
Yeah. My mother told the story of someone that she knew was very pompous. He was a professor of English, and he used to always throw the doctor around. He used to book reservations as Dr. So-and-so. And one night in the restaurant, somebody said, "Doctor, we have a woman that just collapsed. Can you please come over?" And it was like, "Oh, well, I'm a PhD, So, so you've only delivered 2 more babies than I have in my life, probably, right? And I've delivered none. So, yeah.
Okay, so we'll come to a close. I'd like to thank you
Thank
very much